The title is a mouthful. Using multimedia and stakeholder collaborations to enhance HIV adherence, research, and clinical practice in resource-constrained settings. The case of Massachusetts. We struggle with the title, and one of the reasons that it is so long is because we're trying to do a few things here. While the core of the presentation will focus on this, what's now called Massachusetts Project, which is named by our South African colleagues, the broader issue that we really want to frame this around really has to do with advances and where we're all going in terms of multimedia and technology, and how best to utilize it to address which kinds of problems. And I'm actually going to ask, well, what we're going to do today is my colleague Ryan will talk about this Center for New Media Teaching Learning at Columbia, and we're going to talk about the role of in education and public health around media and technologies. Then I want to talk to you a little bit about the South African context and why we chose to collaborate and use multimedia for the adherence intervention work that we're doing in South Africa, and talk about that collaborative process, which we think is fundamental to the success of these kinds of approaches. We'll describe to you the intervention Massachusetts. We'll try and show you some of it through demonstration. And then I'm going to show you, we've completed a grant, and those of you who know about research, we've completed an R34 NIH study, which allows you to develop an intervention and pilot test it, and then tell you about the next steps and what are the broader implications of this kind of work. So I want to turn it over to Ryan right now. Let me just leave that there.
So hi everyone, my name is Ryan Kelsey, as was mentioned before. I'm one of the directors of a fairly unique center at Columbia that's called the Center for New Media Teaching and Learning. And broadly, we support advancing educational practice for all the schools and departments across Columbia, using technology ideally in the most purposeful of ways. And so that means everything from kind of basic course website support for undergraduates in writing, all the way up to medical school, law school, business school, you name it. Just trying to find ways to add value using technology to what's happening educationally. As part of that, we invented or co-opted a kind of approach that fits very well with the kind of behavioral intervention research that groups like the HIV Center, and I would suppose CIRA do here at Yale, and that is something we call design research, which is this process by which we try to really study the audience and challenges of a particular situation that's in need of an intervention, identify some kind of hypothesis that we think will add value and take that forward, and then design an experience, pilot test it, assess it, and have that feed back into new iterations of what we're doing. One of the areas we've been the most successful at doing this with is with a series of projects that we refer to as the Triangle Initiative, and that'll be the kind of the focus of the slice of my center that you'll hear about today. We had a theory a few years ago that these sort of three pillars of what a university does, research, education, and then and kind of community impact or community service, could be woven together using technology, and that if done well would add value to all three areas, all three aims of a research institution like Columbia or like Yale. And the way we do that is through projects like Massachusetts. And so the way that works is we find a research partner who's interested in collaborating, thinking about using media in some way, search out the community that researcher is interested in working in, and through a participatory design kind of process that uses that cycle I just showed, build some kind of intervention in collaboration with the researcher, try it out, and then look for ways to fold it back into the curriculum on the campus. And so the reason for doing that, in our opinion, is a lot of, especially professional schools, public health, social work, even journalism, and other schools, at least at Columbia, are very interested in building more bridges to real practice out in the world, having authentic experiences for their students while they're still studying in classrooms. And we can do that with technology because the tools that we create for particular interventions can be repurposed and subdivided up and reused in different kinds of educational activities. And I'll try to make that more concrete for you later in the presentation as you see some examples that come out of the particular case of Massafucani. But I could just say that throughout these interventions, that we've worked on several of them over the years in dentistry, social work, public health, that there's a way to tease out the sort of competencies and skills that a lot of students need to have in various programs that they're doing on campus. And rather than us making one tool to use in the classroom and another tool to assist the researcher, we just use the same tool and find ways to scaffold it, to use the educational jargon, or just wrap it in contextual material that'll help make that something educationally useful. That's enough for now from me. Let's get to the specifics of what's actually happening in South Africa.
So I've done, and just as other people here at CIRA, other researchers, investigators have, since antiretroviral therapy and combination therapy came into play roughly around 1996, a lot of us have paid attention to the need for high levels of adherence for people to have good clinical outcomes. So a lot of this work is done domestically. Several of us work in South Africa in particular because there's such a high burden of HIV in that part of the world, in sub-Saharan Africa, and particularly in South Africa. So you can see the numbers of millions of people infected, and the numbers continuing to rise of those who are eligible for ART. ART stands for antiretroviral therapy. But there's one physician per 1,300 patients, compared to in the US, roughly 1 per 390. So ART adherence and retention problems are a growing concern. We've made great advances in our treatment for HIV, but we don't have a cure. It's lifelong therapy, and it's lifelong therapy of daily medication dosing. For most people, it used to be 3, 4, 5 times a day for people. For most people, it's 2 times a day, or some can do one a day regimen. But you still have to have extremely high levels of adherence so that you don't develop resistant virus, and again have good clinical outcomes. So what's happening in the South African context is health clinics task shifting to meet the demands and allocate resources. There aren't enough physicians and nurses and very few mental health providers, such as social workers or psychologists, to be available in clinical settings to do what we call adherence counseling, to help patients access care, stay in care, and to understand and have high levels of medication adherence. Our goal is to have people not miss a single dose of their medication. And all of us are human beings, and normal adherence is much less than 100%. Normal adherence is between 50 and 75% or 80%, and that includes all of us. So we need to try and get people above 90%, and that's why there's so much work in HIV about adherence. The broader context there also is the widespread poverty and stigma, and I know people here are working on stigma. A lot of alcohol and mental health problems. Again, this is not unique to this context. We can say a lot about New Haven and New York City and other places in the US. There is limited knowledge among communities and patient population about the concept of resistance and the consequences of non-adherence, the consequences of missing a dose every now and then, or taking a break for a weekend or a week. There are a lot of misconceptions about whether it's okay or not okay to do that. And as I mentioned, the lack of sufficient patient-provider communication, just lack of time for it. And then there are cultural issues around traditional medicine and myths regarding Western medicine. There's a lot of traditional medicine, traditional healing, and people have notions that you should do one versus the other, or you can't integrate them, or I shouldn't take these pills that come from the Western world when I can go to a traditional healer that has other kinds of methods. So a lot of us do work about integrating traditional healing and Western medicine. In this context, there's a strong reliance on lay counselors. They are people who typically come from the community of the populations that are most affected by HIV/AIDS. They are often HIV positive themselves, so they're often peers. But they are lay in the sense that they are not professionally trained counselors. They're not mental health care providers. They haven't gone through a lot of professional training. They get training centrally from an institute called ADDIC, which is part of their Department of Health, from the province. And they basically go through a couple of weeks of basic training on how to counsel people and how to counsel people about adherence. But that's pretty minimal, because it's not an easy thing to counsel people on. So what happens is there's wide variability in the support and supervision that happens in the clinics when these minimally trained counselors go out then into the real world, and they're assigned to clinics, and they're having to see hundreds and hundreds of patients to teach them about adherence and to keep them on track and address problems in people's lives. So there's a lack of standardized curriculum, or the content or a number of sessions. Bottom line, there's wide variability in the adequacy of the counseling that's taking place. And in South Africa also, it was quickly recognized that, not unlike here, but I'd say even more powerfully there's a lot of stigma around HIV, which some of us might think is surprising in a population where there are so many people living with HIV. In some communities where we're talking about 40 to 60% HIV prevalence, you'd think stigma would be reduced, but it's actually unfortunately not true. There's a lot of stigma. So it stays hidden. People are afraid to be tested. People are afraid to access care. They don't want anyone else to know that they're on medicine. So they learned pretty quickly that when medicine became available in South Africa, that as they started distributing it, people who had told nobody in their lives that they had HIV and they were taking medicine had a higher percentage of defaulting or not staying in care and not taking their medicine, because they didn't want anyone to know. So they'd hid it, or they'd forget about it, or they'd take it and then they'd stop taking it. So they developed a policy where people had to identify a treatment buddy, a support partner, that they disclose to and that they actually bring to the clinic before they are given their antiretroviral medication, before they're started on treatment. So that's a policy, that everyone has a quote-unquote treatment buddy. There were concerns about how effectively that was being used, and was the person really a buddy, or was it just someone that they tapped in the waiting room or down the block and said, come be my buddy so I can get my meds, and I'll do the same for you. And a lot of that was going on. And then they weren't necessarily real support partners in the person's life to help them stay on treatment. The old cliche, it takes a village. You know, we're working with a lot of collaborating institutions. You already heard about CCNMTL in our center, but also Department of Psychiatry, University of Cape Town, and the Public Health Department there. There's a social intervention group. There's another group at Columbia University. We work with the city and provincial health departments, which I think is very important. And I know that CIRA actually does a lot of work with health departments as well. And then we collaborate a lot with a specific clinic that we worked in. So here's a picture of the clinic. It's actually a fairly nice, decent, relatively modern building. But everything goes on in this building, pretty much. You know, doctors, nurses, anything that happens, the pharmacy, everything is contained in this one building. But what I want to point out is that this building and this clinic is serving predominantly a local township, which you can see how close and proximal the township is. This is a very, very extensive township of this kind of housing. This is actually a little bit more of an upscale township in that it has electricity. You can see the wires. Each household may or may not have running water. And actually some of the households may or may not have functioning electricity. This is the population that is predominantly being served. And this is just one snapshot of the clinic waiting room. I was looking at this picture last night. You see mostly women and children, and it's families. It's not an HIV clinic. It's a general clinic, but there's a lot of HIV prevalence, so a lot of people are there for HIV care, but not everyone. The men, it serves a lot of men as well. They tend to kind of hang outside and not necessarily sit in the waiting room. So you're seeing about maybe a half to two-thirds of the people that are there to see someone within the next few hours. Okay, so there are a lot of men hanging outside as well. There's Ryan. To talk about the collaborative process. So this happens to be the pharmacist in that clinic. A lot of written paper and pencil records, but a desire to move more towards computer-based and digital medical records. So that's why she's working off a laptop, trying to get the paper and stuff into a digital tracking of pharmacy and pharmacy refills, etc. So we're coming from a research. We've been funded by research from NIMH. We got an R34 grant to address the need for standardized adherence counseling. And I was the principal investigator of a study called Smart Couples, which was, we had done an efficacy trial, an R01 randomized controlled trial of testing an intervention that was the first intervention that was dyadic-based for adherence. Most of the interventions, and particularly at the time, were just patient-centered, just focused on the patient. We said, I had been doing work with serodiscordant couples around sexual risk behavior and family planning and other things like that. We said, let's address adherence in the context of a couple and move this towards a more dyadic support partner kind of thing. So we actually had a successful trial in doing an intervention with patients who were having problems with adherence and their HIV-negative primary partner, wife, husband. We had same-sex couples, predominantly heterosexual couples in this study. So we thought that was a model, a theoretical model and a real model for the buddy system, because that's a dyad. So we thought we could take this notion of dyadic intervention, even though that was couple-based, into a broader, any support partner, whether it's a sister, a friend, a mother, a neighbor, an adult child, or whatever that support buddy is. And this is where then our collaboration began, of thinking about how computer technology can be useful in conveying information, particularly for in low literacy populations. We also want and we think that where we've developed is engaging. It is standardized because the scaffold is in the program, in the computer, and it's delivered by lay counselors. A lot of this is, we sort of framed and approached this as how can we enhance the capacity of what these lay counselors are able to do, which is a little bit different from thinking, what can we build that we can just put patients in front of? So just to say that this came from Smart Couples. What do you see in our logo? Come on, don't be shy. Oh, that's not what it's a smile. Well, right? Most people, when they think, okay, I see two people, it's a couple. Actually, I see a frog. I see a smiling frog. So, anyway. So as I said, this came off of an NIMH R01 trial. It was the first efficacious dyadic adherence intervention. It actually, just very recently, the CDC, I know those of you know about DEBIs and EBIs, but they have effective behavioral interventions prevention. There's a large portfolio of about 70 interventions, primary prevention. They just came out with a recommendation of eight, I think, efficacious adherence interventions, of which Smart Couples is one of them. And they've chosen 5, of which ours is one, for wide-scale dissemination. So that's just the status of that study. But I want to talk, we were going to talk now about our work since then, with the R34 to develop this intervention, assess the capacity of counselors to use this laptop-based intervention, which you'll hear about. We first had resistance about the notion of using a laptop in such resource-constrained settings. We want to assess the acceptability of the intervention among the users and the providers, the feasibility of delivering the intervention in a very, very busy clinic setting, and of course then you do in these R34 just preliminary evidence that there might be some efficacy, or that you might be at least moving in the direction of the outcomes you're interested in. As most of our research is done, it's based in a theoretical framework. In this case, we use social action theory because we think, and I think it encompasses the kind of behaviors and addressing the issues that are necessary when you talk about adherence behaviors. Someone having the information and knowledge. Information is necessary but not sufficient. There's issues around self-regulatory process, about mood and around motivation. And you can throw substance use and that into the whole self-regulatory process. It takes into account this larger social context, specifically stigma and disclosure issues, interpersonal processes, social support, communication, and then the behavior itself. The theory talks about the need for self-efficacy and skills to enact the behavior and to maintain that behavior. The content of the intervention, we've built a lot of things into it. We recognize that mental health problems are a barrier to optimal adherence. While this intervention specifically is not treating mental health problems, we wanted to incorporate the awareness of it. There actually is available mental health services in the settings we work in. Psychiatrists and psychologists rotate through the clinics. They can come and provide psychiatric services and address and treat depression and things like that. But what happens in these settings is they go undetected and undiagnosed. So it's not even recognized that this patient is having such a problem adhering is severely depressed, and no one's even thinking about that or realizing it. So we wanted to develop a screening tool. We wanted to help people choose a treatment buddy that wasn't just the person they tapped in the waiting room, that it was a more thoughtful process. We wanted to impart a lot of information about HIV. How does the virus work? What does adherence mean? What does resistance mean? What does it mean if you don't take your pill? What does it mean to take pills when I'm not sick? And I'm not even feeling sick, and especially if I take the pills and that makes me feel sick. So education around the importance of adherence and what it's doing inside your body. Then, of course, solving problems that are barriers to adherence. And adherence barriers are at many levels. Structural, societal, stigma, interpersonal, personal, individual, motivation. There's a lot of levels where things get in the way of good adherence. We want to incorporate helping people with disclosure and social support, teach a little bit about HIV prevention and transmission and what we generally call prevention with positives, and also couched around reasons to stay healthy. To me, this is a really important slide that I just want to say to you all. And I think a lot of the work that comes out of a center like CIRA, knows this and does this kind of work. But it's really important to involve stakeholders, I think, from the day one of deciding a study, deciding what the aims of a study are, or hypotheses, but also to building an intervention. I know colleagues, and not here at this center, but people who might develop an intervention full scale and then go to a community and say, here, we have this intervention. We want you to use it. And providers will look at it and go, it doesn't make a whole lot of sense, or I wouldn't use that technique. I wouldn't, We believe in working with the stakeholders from day one. And that includes providers, counselors, patient advocates, who are peers from the community, the patients themselves and support partners. We brought them into the process of developing this intervention, as well as researchers, technology experts, and the health department. It was important that we work with the buy-in and collaboration of the health department, because how are they going to institute this? How are they going to scale it up ultimately if it's shown to be effective? And it's an iterative feedback. And you can do that in person, but you can also use technology like Skyping and sites and things like that. And we had a lot of back and forth, which you'll hear a little bit about. So actually, we want to show you a few pieces of the intervention. Do I need to stand next to this one as well, or? You do that. Yeah. Okay. I'll do this because we're going to try and show you a few things in here. Yeah. So I mentioned the mental health screening. So the question we had was, this intervention can't treat depression or anxiety disorder or post-traumatic stress, but can we empower and enable lay counselors to screen for it? Now, there are standardized screening tools for these kinds of disorders. And so we took a standardized screening tool that's been shown to be a good screener, and we put it into the computer. We put it into the computer so that the counselor doesn't have to even necessarily understand what all these symptoms mean, or how to score it, or when you use a screening that's been shown to be valid and reliable, you want the person who's administering it to use the words exactly as written. So they get to use this. Are we showing it, or?
We're just using the slides for these two, but I'll swap over.
Oh, then you'll swap over? Yeah. Okay. So what happens in this, and it's a live thing, you ask the question, the counselor asks the question, and then ticks in the answers. And what happens is the answers get automatically scored. They don't have to sit there and score. They just tick them, automatically scored, and then it automatically scores into categories of no distress, mild, moderate, severe. And then we develop scripts for, if it's severe, just to remind them or give them the language to say, I'd like to make a referral. If it's mild, they say something like, well, I can see you're having some trouble. If you feel like you want to talk about it, you can, but maybe we'll check in next time. But if it's severe, you want to try and intervene and make the referral right then and there. So we'll be studying how successful this is in referrals happening and then mental health care happening as a consequence. So just to describe what it looks like and the scaffolding of it, and we're actually modifying it right now from our pilot study. There's some amount of text that gives the counselor a scaffold for what am I doing now in this session. And so you give a little bit of text of the goals of this session are, a reminder, and then they can go to the session and go to specific activities. So I think we try and go to the support tree. So here they get there, and so this is, we're going to show you in a minute where we started, but this is where we ended up because of our collaborators. And they developed the image and metaphor of a tree as a way of talking about one's social support. And one of the counselors there said, I sit with my patient, my client, and I say, who's in your support tree? And he said, I actually draw pictures of fruit and put names in the fruit. So they sit there and put names in, like Ryan's doing right now. Tell me who's close to you, who's involved in your life. And, Peter and Gabe and Ryan and Bob and Claude, I recognize these names, including Gabe. And then what the next part is, tell me of these people who you've actually disclosed to. Who knows you're living with HIV? So you tick on 3 of those, and the color of the fruit changes. And then my next question as the counselor is, let's talk about who can provide support for you. Emotional support, or food if you are hungry, or can help you with transportation if you needed it, or babysit your kid. And now we've narrowed it down to 2 people that are probably 2 potential candidates for real support partners that really could be a support buddy for you, a treatment buddy for you, and can come and join us for the remainder of the intervention. So it's using this as a way we think of enhancing the capacity of the counselor to go through a thoughtful process that's somewhat engaging visually to think about. And then at any point, we have it set up so that the patient, you can print a print button and they can take home a print of this slide or any of the slides or any of the activities you'll see. So we have a pill activity. It's important that people know what their medicine is and how often they're supposed to take it and how many times a day and which ones they take in the morning and which ones they take at night, because people do get confused. And patients, and this happens here, and I see it in clinical settings I work in, patients think they're being adherent. I take one of these and I take one of these, and then when it's checked, it's like, well, no, you're actually supposed to be taking 2 of these in the morning and only 3 of these at night, that kind of thing. So we put in pictures of the pills. It's a challenge when the pills change, but that's another issue. And then you tick off the ones that are yours, and then you go to the next part, and you can start to move the pills back and forth. So you can do this with the patient. What do you do? Which pills are you taking in the morning? Which ones at night? Depending on how you do this, the counselor should have some basic knowledge of what the regimens are, and to be able to say, well, actually, that's not, you should be taking 2 of these. Or they could always check with the pharmacist or the nurse so that they get it correct. But the timing is also an issue. Ideally, to be adherent and have coverage, therapeutic coverage, you want twice a day to be roughly 12 hours apart, or pretty close to 12 hours apart. 3 hours a day, you want it 8 hours apart. I've seen people who say, I have twice a day dosing, I take these pills in the morning when I get up, and I take the rest at lunch. It's not the best coverage, because that's not 12 hours. So you put in the times, and it's a way of having a conversation about how you're dosing and when you're dosing. We can't show you everything. We can only show you a few things, but I want you to get a flavor of how this intervention works. The island activity. So this was a metaphor that really was developed locally. It's hard to describe viral load, CD4, what are those things? What does that mean? Opportunistic infections, what are those? Health. What does adherence have to do with it all? Our collaborators locally came up with this. We happen to be doing this in a fishing village, and a lot of South Africa is near the coast. So water was a metaphor, island was a metaphor, where if you play with, that's the viral load, if you can't read it. So the viral load's going up, and you can talk about how much virus is in your body. What happens is your CD4s start to go down. CD4 are those cells that help your immune system. When that happens, you have opportunities for opportunistic infections. So this notion of going under the water, what else do you observe going on? with the changes.
They might not be able to pick it up.
Sometimes it's subtle, although on the screen people can see it pretty quickly when you're on the computer. The person's getting skinny when he goes underwater. The notion of illness and HIV illness in this context is identified as weight loss. That's how, and when people say, I think he or she has the AIDS, and they speak in that kind of language, it's, if you're losing weight, that means you're sick. If you're heavy and gaining weight, you're robust, you're healthy. So with these movements, the person looks more and more gaunt. They came up with these kinds of notions and concepts. Okay.
I don't know if you want to do the next part. Or you want to...
No, I think the only other thing we'll show you is the fact that we have videos built in here. So there are other activities like this that are interactive, that you play with things. But what you also built in was, and actually this is a good video to show, because this was actually developed with Yale University collaborators. We didn't shoot or develop this video. We accessed it and used it, and it's in the public domain, and we spoke with the people who developed it. It was folks in South Africa. Jerry Friedman was one of the people involved. And it's called Snakes and Soldiers video because it's a metaphor that got developed for teaching about HIV/AIDS. Let's just show you like 2 minutes or a minute of it.
Right, I skipped a minute up, so we'll start right.
Your body's immune system, or amasoja omzimba, is an army of soldier cells that guard your body from sicknesses like HIV. But HIV is a particularly bad sickness because it not only fights your body, it also fights CD4 soldier cells. HIV is like a poisonous snake, sneaking up to the CD4 soldiers while they are sleeping and killing them. These snakes are small and hide so the soldiers cannot find them to fight them. The snakes also breed very quickly, multiplying until they overwhelm the CD4 soldiers and the body becomes very ill. This is where ARVs come in. ARVs can prevent the multiplication of the HIV virus. It is as if the body's soldiers could find the HIV snake nests and pour drugs on the snake eggs to keep the eggs from hatching. However, ARVs are a kind of drug that only works for a limited amount of time. They must be taken every day, in the morning and the evening. Otherwise, the HIV virus has a chance to reproduce itself.
Okay, problem. So this is a good. You can actually Google this and find it and watch the whole thing. People find it to be very effective, and it just teaches about ARVs. What happens? The resistance metaphor is that the eggshells get hardened, and then if you stop taking the ARVs when the soldiers fall asleep, then when you return to using ARVs, the shells are so hardened that the ARVs are not working on them. And that's resistance. That's viral resistance. There's another part of the video that actually has a whole scenario of 2 characters called Joseph and Hope, which are people who live in South Africa. They're young people. And you see how social support can help, where Hope goes home with her medication and tells her brother who she lives with about it. And you see her in the course of her life running out of the house to go to school and forgetting to take her medicine with her, and her brother reminds her, and she has social support. Joseph hides the medicines from his mother, who he lives with, puts them under the bed, runs out, doesn't take them, starts missing, and you see them over time, and he gets very, very sick. He's really in bed dying. And she's healthy and out going to parties and working, so that also is an effective video. We also developed a problem-solving video that the counselors there wrote a script for how to solve a problem with your buddy helping you, and we then filmed the video, and that's part of the problem-solving. So we don't have time to show you more, right? So we're back at... Actually, I want Ryan to talk a few minutes about the design process and how we got to that support tree, for instance.
So looking at this stuff just on the face of it, it kind of looks like, okay, yeah, well, you picked very relevant things that look like they match very nicely with the setting, but well, we didn't know any of these things up front, and I think it's useful to actually look at kind of where we started and see how the clinic taught us what to do, because we were way off, and I just think it's illuminating. One thing we did as a team of us came to the clinic with some initial ideas and really sat with the nurses, that's one lay counselor there, and really just tried to understand what they're doing and what materials they already had, what kinds of narratives or metaphors they tried to use for different steps in the process. And then we showed them some of our initial designs that we had actually put into the grant proposal. So what I'm going to show you now is what we had drawn up that preceded the tree. So you remember the tree is for picking the treatment buddy. You're going to laugh. Looks very kind of high-tech, right? Looks very kind of, you know, like something you would see on an iPad, you know, or you dragging things around and clicking things, right? And this didn't resonate with them at all, no surprise, right? But we were able to explain it enough to then draw out how they do it, and then we did what they do as opposed to what we had in mind. And that carried through in some of the future designs as well. This is just another screen of our very poor first attempt. The whole idea with the thinning out of the person in the island is similar. We saw these posters in the clinic that were depicting what people look like, and we tried to accommodate that in the drawing that we did with the island. I mean, some of our initial island things were really very ridiculous as well, and I thought they'd be kind of fun to check out. Here's a first couple attempts. We had a student from South Africa who was on the team who had talked about being in the market with scales, and that maybe there was a way to teach this sense of like, well, when the viral load goes up, the CD4s go down. But it's not that simple, and in fact can be counterintuitive in actually helping someone understand this. And again, we're still going toward this kind of very computer-looking kind of thing as opposed to something more human-looking. And we really were taught by the clinic staff themselves, well, don't put a kind of, I don't know, little avatar-looking kind of thing in there. Put a person and actually draw it and make it look like a person would look. And that will make a difference in how well the counselor can communicate some of these ideas to the patients that they're working with. And really, that's really, I want to say that again, just maybe another way that you really think about what we're doing is trying to extend the capabilities of what the counselor can do more than anything else. And so all the design work, the client of the design in a way is the counselor, in order to make them more effective with the people that they're trying to work with. I don't know if we need to do any more than that, Bob, to kind of make the point, right?
Yeah, so
back to you.
Right, good. So, yeah, and so let me just show you these just screenshots. So problem solving we see as one essential. In my Smart Couple study and a lot of other interventions, there's a lot of focus on problem solving. What's the problem? Let's look at it. Possible brainstorm some solutions. Let's think about which one we can try, which one we can't try. And so we also, we were informed what are the common barriers there. So we have about 14 barriers where we have an image, a picture for the barriers, like drinking or being too long at the clinic or the medication makes me feel sick as barriers to taking my pills. And then we developed this video where it's modeling two people, these are two friends, addressing a problem. And again, they wrote the script of the video, and South African actors actually, they were Columbia students who were South African, who we shot the video with. So it's applied to personal barriers. And yeah, I'm not gonna pause on these things. But here's just one example, you know, of what's the problem. Well, when I drink with my friends, I don't take my tablets. That's another word for pills. I don't take my pills. This actually came out of the intervention. So what's my goal? To drink less on the weekends. How can I possibly do that? Well, I can be abstinent, or I cannot drink at all. I can try to take my tablets with me when I go out and be better at that. I can spend less time with my drinking friends. In this example, that was what they focused on, and the buddy actually helped the person stop hanging out with those drinking friends on the weekend, and she found a way to, you know, to help. Let's do something else on the weekend. Spend time with this weekend with a friend who doesn't drink. And, you know, that's just an example, but this is a live example that came out of our pilot study. Okay, and that's Joseph, that's Hope talking to her brother in the video I mentioned. The other thing that we were working with South African fellows who were at our center, and they were looking at this in the early stages. They said, what about people's motivation? Why are they staying healthy? And they said, what about using that whole mountain thing to think about my proximal and my more distant goals? So the proximal, going back to work, person's sick, I want to be healthy to go back to work. I want to get healthy so I can take care of my mother. I want to be there for my son's wedding is the rest of that third goal. The top one is become a grandfather. So this again was live and came out of what someone came up with as their sort of motivating goals, like why is it important to stay healthy? So I'm going to very quick, hi Jerry, I just mentioned your name a little earlier. Let me tell you very quickly, because we want to leave a little bit of time for some discussion. So we did complete the R34 study. So we kind of went quickly through this whole development process, developing this intervention, and then we tried it with 65 patients who were referred for having poor adherence. We mimicked a trial of randomizing them. Interestingly, most of the buddies selected through the support tree process were not the buddies they had selected when they first got their meds. Probably not a surprise, though, right, when you think about how they typically have done it. High retention rate within the intervention. 2/3 were women, and you saw that picture of the clinic, but mostly women. Not highly educated, mostly not employed, and this majority were COSA speaking in this context. So remember the picture of the clinic? This is directly across from the clinic. This is called a Wendy house. You go in and there's a small little waiting room and then there's 2 counseling rooms. That's where a lot of the counseling took place. So this is just one of our facilitators. I just wanted to show you, it's, as Ryan said, this is, we built this as a way for the counselor to have something interactive to work with their patient and buddy. This is not self-directed. You don't turn this over necessarily to the patient and say, here, you know, go sit with this for a half hour and I'll come back. This is an interactive process, interactive. So they look at the screen together. They play with the viral load in CD4 and see the person go up and down and get skinny and heavy. So that's how it's, and they do it in whatever space they can do it in. And this is also why it's not internet-based, why it's all contained.
Who is the counselor? Is the one sitting in front of the computer or is
the one in the middle, the one sitting in front of the computer. For the most part, the counselor manipulated the computer. Patients could, and you know, but they often wouldn't. They would just kind of look at it together. You know, then when they show the video, they just sit there and look at it together. So despite the small sample size, we have promising results. We saw a more promising positive change in days between pharmacy refill, self-reported medication adherence, psychiatric distress, social support for adherence, HIV treatment knowledge. So these are part of the theoretical components of our model for what we were intervening on to improve adherence. I'm going to go through these very quickly. These are small samples. These are just, is it moving in the direction we want it to move in? And so we did see less delay in returning to the clinic to pick up their meds in the intervention arm compared to the control arm. We saw, and this is just self-reported adherence, which a lot of people don't think is a very strong measure of adherence, but we see greater improvement in self-reported adherence for our intervention than control arm. This is just another way of asking a self-reported adherence question, thinking about the last 4 weeks. Social support seemed to improve more dramatically in the intervention arm than the control arm. Since distress is something we assess, now remember this intervention is not treating distress, we are screening for it and referring, we did see improvements in our distress measure, which is that standardized measure in the treatment arm. And finally, we see a crossover and increase in treatment knowledge in the intervention group. But again, these are not statistically significant. These are just, remember, this is an R34 grant. It was really more about developing and the feasibility outcomes. So our outcomes in terms of feedback is our target population found it visually engaging. They like the interactive activities. People love the videos. They really like the videos. And one of the videos, Jerry, I mentioned that we incorporated into this is one that you involved in with the Snakes and Soldiers video that was done in Johannesburg. And so we developed a video, but we also were able to use a video that already existed, that people found had a powerful metaphor. They said they learned things they had not understood, like the importance of adherence, how the ARVs work, and what resistance is. And I love this quote. I learned things about HIV and how the medications work in Massachusetts that I never got from my counselors before. So remember, these are people who had initial counseling, but now they've got this counseling. And they say, you know, I learned things here that I really never understood or heard before. And a lot of support was generated for problem solving. The partners themselves, often living with HIV themselves, found benefits in their own health. They liked helping their friend, learned from problem solving, and they liked the videos. The counselors, remember we framed this as we developed this to enhance their capacity. They were really our main target audience in developing this tool. They felt it was a support tool for them, giving them a roadmap or a scaffold for doing their work, guided me through the sessions, helped me to pay attention to my patient and buddy. And they felt it actually empowered them or enabled them to do that screening, that mental health screening and alcohol use screening, to make referrals to the psychologist or whoever else was available in the setting. And the providers, what they really liked was the standardized tool nature of this. They saw positive changes in the few patients that had been through the intervention. Remember, we targeted people who were having problems with adherence. But they said, you know what, we want this to be used for all our patients when they start antiretroviral therapy. We don't want to wait till they have problems. We want them to understand these things. And the other really cool thing was that the head nurse there, who at first was a little bit resistant, and you know what it's like going to some of these settings like, oh God, research, what do you want to do here, you know, but became a real collaborator. They named the intervention, they developed the metaphors, they feel real ownership. She said, I want all my providers and my nurses and my pharmacists to be trained on this because I want us all to be using the same language. I want us all to refer to that island when our patient comes in. They want the pharmacist to do that. They want the nurse to do that. So they've really owned it and they've adopted it, which is a very nice thing to see. They like the standardized counseling message. They also like the fact that this tool, if a person goes in, it basically takes 20 to 40 minutes to go through a session. And that's what they expect out of their counselors. When someone's having a problem, they refer them to the counselor. They say, you know, I want you to see this patient, and you know, for at least 20 minutes or something. Very often they would witness the person going into the Wendy house with the counselor and coming out in 5 minutes. Well, what happened in that counseling session? Nobody knows. They feel like if this is going to guide them through and put them through a process and standardize our delivery of our messages, great, that's what we want. So we think, to sum this up, that it standardizes delivery of information, provides a guided framework or a scaffold, empowers counselors, visually engaging, very useful for low literacy. It's interactive. You can personalize things. All this information gets recorded about that patient, like their goals and their problems and their problem solving, that you can revisit the next time they come in because it's all there. So it facilitates data collection in that regard. We found it to be highly acceptable and having promise of adherence behavior change. So, you know, thus, and in the research world, you want to go from an R34 to an R01. So we, as soon as we had these kinds of outcomes, we applied for an R01, and we were just funded in August to do a randomized control trial of this intervention. And it was funded on its first submission. And very quickly, because I want to give Ryan a few minutes, I don't have to belabor this. You know, it's an RCT. We're going to develop, but primary outcomes we're looking at are, remember we're starting with people who are initiating therapy, so we want viral load to be an outcome, primary outcome, 1-year follow-up. And we also want what we think of as a more objective measure of adherence. And for those of you who may or may not know, we're going to be using a wild spill device, which we did pilot test in the setting. This is, you can see what it looks like. You can put pills in there. Every time that's opened, a cellular signal is sent. So you can do real-time monitoring of adherence. And it also records opening and closing. You don't know if the person's putting the pill in their mouth, like with MEMS caps. But people have been having success, and a colleague of ours, David Bangsberg, and other people have been using this widely. I'm almost wrapped up. And then we have a lot of secondary aims in this study. So I'm just going to leave that there. Well, no, let me show you this. So this is basically the study. But I actually want, oh, where's that? Just to repeat, there are a lot of collaborators involved, and you see the names of all the people involved. We want to bring it back to the larger context of where we started with what Ryan talked about, and we both talked about how do we think of technology and where and how is it best applied. And that's what actually Ryan's going to talk about for our last slide.
All right, and I'll try to be quick because I know we're approaching the end of the time. So Bob is one of maybe about 6 or 7 projects like this that our center's been involved with over the last 3 or 4 years. And we're noticing a few things. And we thought it would be important to point these out, that something broader than just one particular study that Bob's working on. And that is that, you know, funding agencies like the NIH are starting to put out announcements asking researchers to think through, you know, how to make use of various new media tools, technology. You know, one example I pulled out is, you know, from the Nursing Institute within NIH, has to do with just how do you effectively use mobile health tools. Or mHealth is sort of the catchphrase that's out there. But there are dozens of these coming out everywhere, and it's important to think through, well, how do you approach that as a researcher in this area? And we have a technique and a point of view that we've been developing for a few years now that we think works. And I've just tried to summarize that in these 3 bullets here below with, you know, thinking carefully about, well, what is the role of the tech in the intervention? And as we've said 20 different ways today, we're talking about enhancing person-to-person communication in this instance, not replacing or trying to just find the latest gadget out there and leverage it, you know, for some outcome that we're not so sure about, but instead to really carefully, with a very close participatory design model, ID a problem that we think technology can add value to, and then really hone in on that really carefully. Going bigger than that, I hope that, and I think I summarized this a bit in the beginning as well, that the things that we're learning and putting into these tools can find their way into other parts of university life, whether that's taking some of the videos that are developed and putting them into a classroom just to learn some of the basics in the same way that the patients have to learn the basics, or critically analyzing like how well we've culturally adapted this particular intervention to this setting, and having public health students really examine that carefully, or maybe think about a 3rd setting or a 4th setting. And there are ways that we can not have to rebuild the tools and still get a, you know, big value add in terms of an authentic experience for students in classroom settings. And to me, the way to make this really happen is, and the reason I'm so proud of what we've done so far and so looking forward to seeing what we can do in the next study, is really this CBBR process that took place in this particular project. I've never seen it happen as well as it did here. It's a credit to Bob and the collaborators in Cape Town and everyone else that we work with, that we were able to get the clinic so wrapped into helping us make what we've made, which I think I said to some of the fellows earlier when we were here this morning, that building the tech product or buying the tech product or however you choose to incorporate it into some work that you're doing is only one of about 8 things that have to go right for one of these studies to really work. Everything from, well, how do we train the counselors appropriately? How do we create a kind of welcoming environment that the tool will be accepted in this setting? And I mean, just one little detail we never mentioned, it's in English. Well, you wouldn't think that we'd want to do it in English, but the clinic insisted, please do it in English. The pharmacy bottles are in English. The way the medical terminology is communicated is in English. Don't change it. And you know, the counselors can do the translation as needed. There are a lot of issues like that, and we should. I just suggest that, you know, anybody thinking about ways of using media in these kinds of tools should try as best they can to really get the people that you're targeting involved in the process, because it'll just pave the way for a better implementation and a better chance for success going forward.